So we have the chance today to have with us Piero Montorsi, professor of cardiology of University of Milano, Italy, and director of the Centro Cardiologico Monzino. He will talk about the use of the radial access in carotid stenting. So Piero.
So thank you, Jean, for the presentation. So let's move on into this nice field of modern cardiology. Here comes some preliminary background. We know for sure that specific anatomy and variant of the supraortic vessel are associated with a higher risk of cerebral embolization during transfemoral cast, so the standard of care so far, calling for an alternative approach that may be the transradial cast. That's the background. So in favor of this background, favorable result has been already proved with transradial cast in single series and in one randomized controlled trials. And of course, needless to say, interventional cardiologists are familiar with radial approach for the vast experience with coronary PCI. On the other side, transradial cast is much more technically demanding than coronary intervention, requiring dedicated system and techniques and a steep learning curve. The other thing is that the radial artery size, that is small, of course, may not allow the use of large devices, and I refer, of course, to the A-French proximal protection MOMA device. It's quite important tool in our armamentario. So why is so difficult may be so difficult transradial approach? For three reasons: tortuous arterial pathway, hostile bifurcation, can you see the acute angle, and lack of anatomic support in critical areas that make the getting around this bifurcation quite complex from the radial. So here comes the indication at our institution when we start this program, are the anatomic indication, of course, bovine aortic arch with left, type 2 or type 3 aortic arch with right stenosis. This is a very peculiar situation of a very hostile bend of the nominate with right. Of course, nothing to be said for aortic arch disease, had no peripheral pulses to come from femoral. So we started the first part of our learning curve, 100 patients. Then we went into the second phase that, of course, include all comers. And now this is the final numbers we did so far, 555. So there are also some clinical indication as for coronary intervention, high risk of bleeding patient requiring early mobilization of intervention, patient preference, shorter hospital stay, less care cost, or of course, failure of transfemoral cast. Don't send the patient to surgery. You can also manage the same patient from an alternative approach. So let's show you the three anatomy. The left, bovine, the right, wide angle and acute angle, and the left that takes origin from the aortic arch. These are some preferred diagnostic catheter to engage the vessel. These are the technical difficulty from very low in this case to more complex in this case. And here comes the two type of technique that we use in transradial cast, the anchor technique or the coaxial technique for these two types of anatomy, and a mix for the other one. So let's start with the first setting is the bovine aortic arch. Can you see the CT angiography and the screen? So let's start for this case where you see that 0.35 Terumo wires go nicely deep into the bifurcation by itself. Once into the bifurcation, you can, of course, push the guiding catheter, the diagnostic catheter 5 French below the bifurcation, and you are ready for the DCA baseline. At that point, if you change the Terumo with a stiff wire, you can advance the 6 French guide over the stiff wire very smoothly, and you are ready for the procedure when you have already selected a distal filter as a type of protection. We did so far 142 cases, 100% technical success. Here comes the second setting. It is the left common taking origin from the aorta. Here comes the coaxial system. 5 French SIM 2, 125 centimeter long, within a 6 French coronary guide, 90 centimeters. This is the 5 French diagnostic and help the Terumo wire to go down into the descending. The second step is to advance the system, the coaxial system. Here comes the SIM 2, and we stop the advancement close to the start of the descending. At that point, we remove the wire and we prolapse the system down towards the aortic valve, and we finish the first part of the technique. Here comes the second. We call it true fissing technique, the true engagement of the left common from the aorta. Here it comes. We have to do a catheter counterclockwise rotation in the mid-aortic arch to form what we call an open 8 sign. We check in the right position with contrast. We are close to the subclavian. That's a good position. Then we push slowly and continuously the catheter, and it enters spontaneously into the common, and you are ready into position. That takes you 15 seconds. Okay, that's the third and final setting. So it's a right stenosis, right common with a very acute angle. You start again with a coaxial system as before. I'm going to show you the entire vessel, the entire maneuver we have to do. Here the same scene to the descending. We remove the wire, prolapse down, and then we rotate and pull it back into the ascending. Then we turn the projection from left 45 to right 45. We enter the right common with the Oterumo wire, and we pull the catheter back smoothly below the bifurcation. At that point, keeping still the Simmons, we advance the 6 French guiding that we park into the subclavian. And once again, in 15 seconds, we are below the bifurcation ready for the procedure. So 45 seconds to enter a very difficult anatomy. So if there's some room left from transradial approach for use a proximal protection, we are very fond of this type of protection. So we use this type of introduction is an 8 French sheath called brachial, 5 centimeters long, and we inserted this type of sheath for 1/3 of its length, not to damage too much the radial artery. This is a different approach with a higher puncture with a very high, tall patients, or you can choose also the sheathless approach. So here comes how does it look like when it's in place. Good flow into the radial. Here is our experience as summarized. 137 patient did so far, 92 from radial and 45 from brachial. Here comes the endpoint, 97 device, 97 the technical success, 95.6 the procedural. Interesting crossover, only 2.18 in the very early part of the learning curve, MACE 1.45, vascular complication general, and 7% as a radial chronic occlusion asymptomatic. Here comes a very typical case. It was bovine type 1, very complex anatomy. The stiff wire is already into the sternal, and looks how smoothly and easily, once again, the MOMA devices go through this pathway and enter the target vessel. Finally, if you fail from the transradial, from the femoral approach, very difficult case with very tortuous anatomy, and after more than 1 hour, we stop. We decide to go from the radial, and it take us 5 minutes to be with the guiding catheter below the bifurcation. That's the lesion. We put a 7 millimeter spider protection. Here it comes how nicely the Rotsaver 9x20 go smoothly through this series of bend and curves, and within some seconds below the bifurcation. At that point, we conclude with the standard technique, and that's the final result. So here comes the very final result of our 555 patients, very nice. That's really 1.0 complication, 1.62 the major, and 7% the radial. So, John, just to conclude, we have to say that you want to embrace this type of new technique. Precast images is mandatory. And we advise to start with the back first, bovine and left, then right wide angle, then left from the aortic arch, and the right with the acute angle. But leave cases from the femoral approach as well. Have a good relationship with bends, angulation, tortuosity, more than you already have with the femoral approach. This is a land of bends. Taking advantage of coronary equipment anytime while learning use of new catheter, Simmons, and some technique, coaxial technique with rare use from coronary artery. And start cast with filter first, then taste proximal protection. The goal is to use all the armamentarium that we are currently adopt from the transfemoral approach in order to make transradial cast not an alternative, but a first-line approach in the future. Thank you so much.
Thank you, Piero, for this really fantastic talk. It's really impressive. I have quite a huge experience of transordinal access for coronary intervention.